This program is brought to you by Emory University.
Good morning. Our speaker today is Dr. Francisco Pasquel, who did his medical school training in Ecuador and then did residency and fellowship at Emory and did a postdoc at Yale. He'll be talking about diabetes and cardiovascular disease. Arshad and I were talking about how our different specialties have become divided over the years. But in recent years, it's really going to be the burden of knowing diabetes management is going to be on our cardiologists. Well, we cannot ignore the clinical trials that are coming out that are showing improvement in outcomes, not only in our patients related to coronary disease, but related to congestive heart failure. So I'll turn this over to Francisco.
All right, good morning. I really apologize for the delay, so I might skip some slides to try to get a little bit to the studies that of interest. So, I guess it's very well known that cardiovascular disease is associated with diabetes, and I guess the point of the lecture is to try to discuss a little bit about the change in paradigm in the management of diabetes and cardiovascular disease. In general, we've always thought that metformin is the medication of choice that might help us decrease some cardiovascular events. But in the last few years, we've tried to understand if treating diabetes will help prevent cardiovascular events. We know that there's a direct association, a causal association between hyperglycemia and complications in diabetes. So higher blood sugar levels are associated with especially microvascular complications. That's very well known. You can see the linear relationship between A1C levels and microvascular complications. But in patients with type 2 diabetes, in general, we know that they suffer from the complications of diabetes from hyperglycemia, so blindness, kidney failure, amputations. But most of the deaths, the reasons for death are related to vascular events. So a patient in their 50s, for both male and women, might have maybe 6 years of life lost just because of having diabetes, and most of those deaths are going to be related to cardiovascular disease. So one of the points in this association between diabetes and cardiovascular disease was raised several years ago when we thought that diabetes was a cardiovascular equivalent, a coronary equivalent. And with time, we've learned that maybe that association has to do a little bit more with how the patient is controlled, how long the patient had diabetes. So in this data of several thousands of patients in this cohort, they analyzed patients with history of diabetes and coronary heart disease. And what this slide illustrates is the different kind of types of patients with diabetes and the risk of incidence of coronary heart disease. So here in blue, you can see that there's an increase over time in risk, obviously, as in the general population. So these are patients without diabetes and without coronary disease. And if you compare those patients with diabetes only, they're relatively similar to those patients that do not have a history of coronary disease, a little bit higher over 6, 7, 8 years. But when they analyzed those patients that they labeled as severe diabetes, and they called severe diabetes as the patients that are using insulin, so diabetes that is more advanced, or those patients that have microalbuminuria, which is a marker of coronary disease or endothelial dysfunction. And you see that those patients that had severe diabetes, they actually do have that kind of coronary equivalent. So comparing to patients that do not have diabetes and have history of a previous event. But if you can see, obviously in green, this is the magnitude of that association of having a history of diabetes and a previous history of coronary disease is much, much higher. So these are the patients that have been enrolled in several of the recent clinical trials in the sense that we're trying to prevent events in these patients with with this new drug. So, and if there's any new drug that is coming to the market, at least has to show that it's not increasing cardiovascular events. We know that over time, the number of events in patients, both with diabetes and without diabetes, has been decreasing. So there's less strokes, less heart attacks. Overall, the complications of diabetes have been decreasing over time. But obviously, when we look at the population level, that's been reproduced in other countries. We know that the number of patients continues to increase in terms of millions. So even though we're decreasing the number of events, the magnitude of the drop is higher in patients with diabetes. There's still a gap between diabetics and non-diabetics. Diabetics die more from these complications. And we see that the standardized rates are going down, but obviously as the population is aging, the number of people that is having complications related to this is high. So typically when we think about atherosclerotic cardiovascular disease, we think about the comorbidities that are very common in our patients. So when we go to our clinic, most of them will have at least hypertension, dyslipidemia, obviously insulin resistance. And a large proportion of all our patients with type 2 diabetes, at least 80%, will have a combination of some of those risk factors. So when we think about specifically about managing hyperglycemia to decrease cardiovascular events, there have been several studies that tried to just lower A1C and see if that is associated with a reduction in macrovascular events. We've learned from the UK-PDS, the largest trial in newly diagnosed patients with type 2 diabetes, that the main reductions in complications in these patients was related especially to the management of hypertension. There was a subgroup of patients, obese patients, that were treated with metformin that seemed to have better cardiovascular events. But we know that with intensive insulin therapy lowering A1C in these patients, the benefit is mostly in microvascular complications. So the studies that looked at reduction in A1C were the large trials published several years ago. There were 3 trials, the ACCORD trial, the ADVANCE, and VADT, and they were targeting an A1C of about 6.5 or 6 in these patients. And actually, these trials couldn't show any benefit in cardiovascular events, and the ACCORD trial actually showed increased mortality in those patients randomized to the intensive arm. So since then, the guidelines changed. We don't need to be that aggressive with patients with diabetes. We shouldn't be aiming to an A1C of 6.5 or 6 because we might be causing harm. They all showed some benefit in microvascular complications. So in terms of looking at all those trials together, really, when we look at the events, maybe some reduction in myocardial infarction, but in general, the outcomes were not improved in the analysis of intensive glucose control in these trials. So this slide is basically just showing that the benefit in microvascular disease in general was seen in those trials, but not in microvascular disease. So in the last several years, we've had all these new medications coming into the market. Obviously, when we were talking about management of diabetes about 10 years ago, what we have available were TCDs, sulfonylureas, and metformin. And TCDs, the one that stayed alive, is pioglitazone. We still have it, but there was a major issue with the association with heart failure, as you know, especially with rosiglitazone. There was a meta-analysis published by Dr. Neeson in the New England Journal that showed an association with maybe an increased risk of myocardial infarction. That was reanalyzed. It didn't seem to be real, but what was real is the association with heart failure with the use of TCDs. And in the last few years, some of these medications have been approved for the management of diabetes. We really don't use them, but they might reduce A1C by 0.5%, et cetera. But the main ones, the most important ones, the most attractive ones that we're going to discuss are GLP-1 analogs and SGLT2 inhibitors that have been in the market for a few years, and also DPP-4 inhibitors. So when we go back to that analysis of TCDs and mortality, we learned that with the new meta-analysis in terms of cardiovascular death and risk associated with thiazolidinediones, actually there was not an increase in mortality associated with the use of these medications. But what was real is this association with increased risk of heart failure with the use of rosiglitazone, especially almost nobody's using that medication anymore. And the association was also significant in the pooled analysis with maybe a 30% increase in the risk of CHF with the use of pioglitazone. So since then, FDA said, from now on, any new drug that gets approved for the management of diabetes has to show that it's safe in patients with high cardiovascular risk. And what the FDA said is that all the new trials that are coming out, all the drugs that are coming out to the market have to show that there's no increase in the risk of major adverse cardiovascular events. And the mandate, as usual, as you're familiar, those outcomes, those primary outcomes in those trials have to include CVD mortality, non-fatal MI, non-fatal stroke, and some of them will add heart failure, revascularization, etc. But those three main outcomes have to be considered. And to show non-inferiority, essentially in pre-approval trials, the upper limit of normal of the confidence interval, obviously when there's smaller trials, there's less precision. It has to be less than 1.8. But what we're really looking at is to the new trials that have been large trials post-approval that have been aiming to show that there's no increase in risk, and that was defined as an upper limit of the confidence interval below 1.3. So in the last several years, there have been several articles in major medical journals that have published the results of the studies that have included patients with very high cardiovascular risk with diabetes with these newer medications. One of the initial ones was the ELIXA study. This was the first one with a GLP-1 receptor analog called lixisenatide. And that study was the first one and actually didn't show any signal of benefit or harm. And this was a study that included patients with just a very recent coronary event. They were immediately randomized, but probably in this study, everybody went on a statin, everybody went on aspirin, very high-risk patients, but the benefit of GLP-1 or anything was not seen in this study. And then the major trial that kind of started changing the way we looked at the management of diabetes in patients with heart risk was the EMPA-REC outcome trial with empagliflozin. And after that, we have a series of cardiovascular studies that have been published that we'll review in the next few minutes. So DPP-4 inhibitors. So these medications are oral medications. They're very well tolerated. They're very, very safe in general. They're not as potent as the other one. They might reduce your A1C by about 0.6, 0.7%. And there have been about 4 or 5 major clinical trials. What we learned from the studies with DPP-4 inhibitors, they enrolled, again, patients with very high cardiovascular risk. And the first 2 studies that were published were with alogliptin and saxagliptin. And there was really no increase in cardiovascular events. They were considered safe. However, there was an increase in hospitalizations for heart failure with saxagliptin, and there was a numerical imbalance with the use of alogliptin. So since then, FDA said maybe we need to be careful in patients with history of CHF, maybe patients with renal disease with these 2 medications because of that risk. However, the study with sitagliptin showed no increase in risk for heart failure or cardiovascular events. And the most recent trial, Carmelina, with linagliptin, also no signal about heart failure. So they're considered safe medications in all patients with established cardiovascular disease and diabetes. What we learned from those trials is also that there might be an increase in the risk of pancreatitis. That's been very well known. This is just the communication of FDA saying that we have to be careful with saxa and alogliptin in patients with heart failure. So that might be relevant for your practice. We don't use them that much, but maybe saxagliptin, some patients are still using saxagliptin. So, and then we have, after the PP4s, we have the studies with SGLT2 inhibitors and GLP-1 receptor analogs. These are the kind of the four initial studies that started changing the way we manage or we think about the management of diabetes. Empagliflozin, canagliflozin, and most recently, this past year with dapagliflozin in the DECLARE study. And then we have liraglutide, semaglutide, and we have data with exenatide, albiglutide, published more recently. So SGLT2 inhibitors, if you're familiar, they're medications that work in the proximal tubule. They block the reabsorption of sodium and glucose. So they're blocking this transporter that increases the reabsorption of sodium and glucose, and basically are changing the threshold for that. So with glycosuria, patients are having glycosuria kind of immediately after taking these medications. The effect can last even a few days after stopping the medication. And what they're causing is this osmotic diuresis associated with glycosuria. We've learned about some of the side effects associated probably with increase of glucose in the urinary tract, with increase of UTIs, and yeast infections, etc. But what we learned from EMPA-REG is that the primary outcome for this study, the 3-point MACE with cardiovascular death, non-fatal MI, non-fatal stroke, showed superiority, not just inferiority, where there was a 14% reduction in the risk of events for the primary outcome. And I think what is interesting about this study is that this curve started separating pretty early. So if you can see, if you think about studies with statins or some of the GLP-1 that I'll show, typically you will see the two curves, and they will start separating maybe in the next year, 12 months, 16 months or so. This was really, really early. So the thought is that maybe these medications are having some benefit. We don't understand why, but it doesn't seem to be changing the natural history of atherosclerosis. It's unlikely that these medications will have an effect that quickly. And when they looked at admissions, where am I? Sorry, wrong direction. When they looked at hospitalizations for heart failure, and this is cardiovascular death, you see that the magnitude of the difference it's quite impressive with the use of empagliflozin compared to placebo. Cardiovascular death much lower, 40% reduction with this medication. When they looked at individual components of the primary outcome, cardiovascular death, you see that the magnitude is much higher for cardiovascular death, but doesn't seem to be explained by a reduction in strokes, for example. Actually, strokes are in the wrong side. There's a potential increase. They couldn't explain very well why this happened, but this benefit doesn't seem to be related to a reduction of strokes. Non-fatal MI on the left side, and when they analyzed the data on heart failure, was quite impressive. You see that the reduction was pretty soon, decrease in hospitalizations for heart failure immediately after starting this medication. About 35% reduction in hospitalizations for heart failure with the use of empagliflozin. And this was consistent with both doses of medication, giving it some internal validity to the study with 10 or 25 milligrams. So quite impressive impact on this. Some of the effect that we've learned with both SGLT2 inhibitors and GLP-1 receptor analogs is that they actually also have some beneficial effect on kidney outcomes. There's a reduction in nephropathy, worsening nephropathy, or incident nephropathy with these medications. The next study was CANVAS with canagliflozin. Again, similar type of patients with very high cardiovascular risk. Just the history of diabetes of about 14 years. They had a couple of subarms with patients with more renal failure. What this study showed was again a reduction in the primary outcome, 14%, very similar to what was shown with empagliflozin. And essentially now we had two studies showing the same kind of benefit, and again confirmed with dapagliflozin. In dapagliflozin DECLARE study, they had an outcome looking at cardiovascular death and hospitalizations for heart failure, and it was significant. So we have this class of medication that seems to be reducing cardiovascular death, and it seems that the impact seems to be quite significantly related to a benefit in heart failure. Really no impact in stroke in those trials with DAPA or canagliflozin as well. The next studies, as I mentioned, was ELIXA, no effect, and then LEADER and SUSTAIN came out. So LEADER is the study with liraglutide, and SUSTAIN is a study with semaglutide. Semaglutide is a once-a-week medication. And what was seen with liraglutide, similar reduction in the hazard ratio, same MACE primary outcome. You see that the curve starts separating maybe 18 months after exposure to liraglutide, and there was a significant reduction in outcomes. Death of cardiovascular death, also significant with liraglutide, but it takes quite a bit for that effect to be apparent with the use of this class of medications. So when they looked at subgroup analysis in patients, it seems like there was a consistent reduction in all subgroups of patients. There was an interaction for patients older than 60 versus those older than 60 in CVD and CKD. So those with CVD and CKD seem to have a little bit of benefit, but in general, the effect seems to be consistent for all subgroups of patients. Hospitalizations for heart failure in that study, really no signal of benefit, really no significant effect over time as seen with SGLT2 inhibitors. Okay, so we have with GLP-1 receptor analogs. Not sure what's going on. Let's hopefully it comes out. I guess this slide is just pointing out that difference in effect, I guess, with empagliflozin, the very early effect with SGLT2 inhibitors versus the impact with GLP-1 receptor analogs seems to be a little bit more delayed, maybe modifying the natural history of atherosclerosis. Again, just showing that maybe with GLP-1 receptor analogs, there's all the outcomes are on the left side for all the individual components of the MACE primary outcome, and maybe on the wrong side or no significant with stroke with SGLT2 inhibitors. So, what is the number needed to treat? These were patients that were already treated with statins, already treated, a large proportion of them already treated with ACE inhibitors. And I guess the point of this slide is that showing that most of those patients were already on medications that will reduce cardiovascular disease. But I guess the point is that adding this medication might add some additional benefit in patients that are already treated with these medications that we know will decrease cardiovascular risk, and the number needed to treat around 39. With canagliflozin, the number needed to treat was around, I think it's close to 200 patients, so quite higher in comparison. With GLP-1, with treatment with liraglutide for 3 years, the number needed to treat around 100 patients to decrease one cardiovascular death, to decrease one outcome, about 66 patients, a little higher than with SGLT2 inhibitors. So the question comes next is, what do we do with our typical approach to the management of type 2 diabetes? So this has been the typical approach. Patients come in, have a diagnosis of diabetes, and always metformin is the next choice. And then what we used to do is we can use any of these other medications according to efficacy, risk of hyperglycemia,
potential side effects as weight gain, cost, etc. Sulfonylureas, we're using them still a lot because they're very affordable and effective. But I guess the point is that now we started thinking about SGLT2 inhibitors and GLP-1 receptor analogs, especially in our patients with established cardiovascular disease. And then this started to come out in 2017. Okay, it sounds like we need to start thinking about the use of these medications in people with higher cardiovascular risk. In comparison, GLP-1 receptor analogs compared to DPP-4s are more potent in reducing A1C. We know that basal insulin is potent reducing A1C, but there's no signal at all. There's a study with degludec, there's a study with glargine, no significant reduction in events. But I guess that the point is that now we might need to start considering heart failure in all our patients when we're using these medications. We learned that maybe there's an increase in risk with saxagliptin and alogliptin in the risk of heart failure. We know that we need to be careful with pioglitazone because of the risk of heart failure hospitalizations. But now we have SGLT2 inhibitors as a medication that will decrease both MACE and specifically heart failure. So when we're thinking about how we manage diabetes, I guess the STENO trial is one of the studies that tells us what we want to hear, that it's probably not only A1C, it's not only statins, it's not only blood pressure. This was a study enrolling patients with history of microalbuminuria, long-term diabetes, and I guess the point is that intensive treatment is much more important compared to conventional when we're targeting all those different variables. I think you can see over time is not a large study, but showing the point that there was a quite significant reduction when we target all those components. So I guess the point of this slide is that we should be targeting all our ABCs in patients with diabetes. So when we think about the management of diabetes, A for A1C, B for blood pressure, C for cholesterol. Now we can think that maybe for patients with advanced cardiovascular disease, now we have medications that target this pathway but are having a significant impact. So let me just see here. I can probably go to the other slides. So how do these medications work? I think I have just a few more minutes, but I think it's probably more important to look at this. So how do these medications work? How did I open this again before? Well, this one's, oh yeah, here, full screen. So what do SGLT2 inhibitors do? So these medications work in the proximal tubule. They actually also there's transporters in the alpha cell in the pancreatic beta cell, and there's in a potential increased risk of DKA with these medications. There was actually a communication that just came up a couple of days ago from FDA. Kind of declining the use of SGLT2 inhibitors for type 1 diabetes with SGLT2 and SGLT1 combination. But the point of this slide is to try to understand what does happen with this medication. We know that there's an increase in ketone levels in patients that take this medication. SGLT2 might go to the alpha cell, block the transporter, and maybe the alpha cell doesn't get enough glucose inside the cell. Maybe that's triggering a production of glucagon, which is the main mediator of ketogenesis. And when there's a reduction in the use of insulin, there's maybe more lipolysis, more activation of hormone-sensitive lipase. But the point is that in patients, we know that SGLT2 inhibitors will increase. There's an increase in free fatty acids and the production of ketones. And maybe one of the thoughts is that the heart is actually more efficient in consuming beta hydroxybutyrate. So the thought is that maybe this increase in ketones is beneficial for the heart, and the same postulate for the kidney, and one of the other points in patients with heart failure is the thought that maybe these patients are also having some hemo concentration with higher levels of hematocrit, maybe more oxygen delivering to the heart. So these are some of the thoughts of how these medications are impacting the heart directly. Obviously, the volume part in osmotic diuresis is probably likely one of the main events. But one of the side effects also associated with SGLT2 inhibitors is the increased risk in amputations. And how does that happen? It's not well known, but there's a significant risk, especially in canagliflozin, in the risk of amputations, particularly in patients that have previous amputations. That's really not well understood. There was I think I don't know if the article was published already, but there was an analysis, I think it's in patients with diabetes as well, that are using diuretics, just diuretics in general, and there seems to be an increase in amputations in patients with significant vascular disease or history of previous amputations. So the thought is that maybe there's a decreased perfusion to those ulcers, decreased perfusion to the lower extremities, and maybe that's what's causing those problems. So there's all those additional risks that we need to consider with the management of these medications. Typically, when we start an SGLT2 inhibitor, either canagliflozin 100 milligrams, the typical discussion with the patient is there's an increased risk of amputation with this medication because it's all over the news. So I will look at the patient, see if there's any ulcers, there's no lesions, I feel totally confident. But for those patients that have previous history of amputations or ulcers, we will avoid those medications. Those medications increase significantly the risk of yeast infections, vaginal infections. So in patients that have recurrent infections, we have to tell them that we might just treat it. We'll give the medication. If they have an infection, just treat it. If it comes back, then we might stop the medication. But that's the typical discussion. Let the patient know that about maybe 5 to 10% of patients will develop yeast infections with SGLT2 inhibitors. And the other point for the use of these medications is that they are also increasing the risk of ketoacidosis. There's mechanisms that explain how this will happen. And there have been several reports of DKA in patients both with type 1 and type 2 diabetes. So the risks, when does it happen? Typically, ketogenesis occurs during fasting. So patients that are going for surgery, or there's a plan for surgery in those patients, we will tell them to stop the medication maybe 2-3 days before that. Otherwise, there's an increased risk of DKA. The risk in type 2 diabetes is much lower, but we have seen it. And the problem with that is that it might last maybe 2-3 days. Some patients have been on insulin drips for 3 up to 5 days. And there's several reports I've received calls from colleagues saying, hey, this patient is not recovering. What do we do? So measuring ketone levels, et cetera, keeping the drip and then transitioning. So that's another of one of the considerations with these medications. With GLP-1 receptor analogs, we will not have this benefit on heart failure. The main side effect with GLP-1 receptor analogs, I don't think I have a slide here. The main point with GLP-1 receptor analogs is that there's an increase in nausea and vomiting. So that's the main discussion with the patient. So these medications lower gastric emptying. These medications do not cause hypoglycemia. They go to the beta cell, increase insulin production, decrease glucagon levels, increase satiety at the level of the brain. But just because of that reduction in gastric emptying, the patients might get more nausea, especially when starting this medication. So what we will tell them is, especially during the first few weeks, you might have increased nausea. That will likely go away. Try to not overeat. If you overeat, you might have more nausea with these medications. The risk is lower with the once-a-week medication. Several of the new ones are once a week, and we will tell them that this is very likely to happen. I typically will tell my patients this medication is likely going to cause nausea. It happens in about 2 out of 10 patients that take it, but it will go away. So give them some reassurance. Tell them that they might have some bumps or lesions in their skin after they take these medications. so that they are aware depending on which one. There's some that give a little bit more side effects. So I just wanted to mention, and well, with DPP4 inhibitors, there's a pooled analysis of the increased risk of pancreatitis. So if you have a patient, you want to start it on a DPP4 inhibitor, they're very safe. They will not help in reducing cardiovascular events, but at least you will feel safe with these medications. But I will be concerned with the use of saxagliptin and alogliptin for the risk of heart failure. It's not very understood why, but there's those results with those two medications. And I'll stop there in honor of time. So thank you, and again, apologize for coming late. So.
I think some of the curves on cardiovascular events are very, very impressive. If you look up the relationship between diabetes and heart failure, you'll read that diabetes is a risk factor for cardiovascular disease and heart failure. If you look at our clinical trials in heart failure, it turns out that 25% of outpatient trials, in outpatient trials, 25% of patients have diabetes. In inpatient trials, 40% of patients have diabetes. And if you look at the current LIFE trial that we're doing in class 4 patients, it looks like there's going to be around 55% of the patients have diabetes. So it actually turns out that worsening heart failure is a risk factor for diabetes, and that we've known for years that heart failure in part was a neuroendocrine disease, and it's those stress hormones. We've seen patients who've had very poorly controlled diabetes who went on left ventricular assist devices and normalized their hemodynamics and had better glucose control. So just a word in of how we look at, we can no longer look at and labeling people as diabetics and having risk factors, but we have all these relationships that are coming out through these trials, and these SGLT2 trials are very, very interesting. So let's open it up for questions. And Arshad, I'd like for you to make a comment about the app that you have, but Kushra.
Very nice presentation. About the amputation, it would be interesting if they would study patients who have got significantly abnormal ABI. If they are excluded, will the amputations be still high when the ABI is normal? And I think, I know you alluded to that if you look at patients, if they don't have a wound or ulcer, that means the risk of amputation is low. I think the safest thing is just getting an ABI. It's like diagnosing diabetes by saying, do you have polyphagia, polydipsia, and not checking hemoglobin A1C.
But yeah, and people don't understand the mechanism, so that's, I guess, the main concern. And then once they found those increased amputations in the study with canagliflozin, everybody freaked out and said, like, from now on, we're not enrolling those patients. And I don't think we're doing that. But I guess it's a good point. And the mechanisms are not understood at all. It's just we just know that there's that association, and I'm sure people is trying to understand a little bit more about it. And I know there's a potential for a new trial to be approved. I think Guillermo, in collaboration with Dr. Kuyumi, that is looking into this. And there's studies that using SGLT2 inhibitors in patients with and without diabetes. And the outcomes is obviously heart failure. And there's a large trial, the CVD real study, that actually show that this benefit is being seen in clinical practice. They have analyzed the data from Europe, US, and with the prescription of these medications, there's a significant reduction in hospitalizations for heart failure and cardiovascular mortality. One of the thoughts of this new trial is that maybe we should be starting this medication early. And the point is to try to use these medications in patients that get admitted with heart failure to the hospital and see if one of these medications started at discharge might help reduce readmissions. So there's a lot of interest in both patients with and without heart failure for this.
Thank you. I just wanted to add a couple of things. One is that we, as you know, see a lot of patients with diabetes and in our clinics, and hardly anybody is on these drugs, it turns out. Occasionally you see somebody is on a Cana or one of those. Yeah. And we're always wondering, how do we start this? Because they generally have an appointment with an endocrinologist after 3 to 6 months. their primary care is not going to start these, and we sort of advise them to get this started, but we have no idea. We don't know which A1C it is safe to start in, which drug to start, where do we look at legs, and where we look at heart failure, so it's very complicated.
Right.
But clearly, a lot more diabetics are being seen in cardiovascular clinics and internal medicine clinics than in endocrinology clinics in terms of numbers and frequency. So with the help of you and Guillermo, there's this app, right, and an algorithm that's been made up very simple in order to assist non-endocrinologists commence these drugs in people who have diabetes with the right criteria. And so Devinder, who's a research fellow here and has sort of written up this grant, which we've applied to the Diabetes Center grant
Oh, the
thing. But
P30.
regardless of that, which may be in competition with yours.
Yeah,
but,
I know.
the point is that regardless of that, we would like to start this in cardiology clinics, and would ask physicians who are cardiologists to see if they would participate in this, so that at least half of them would receive the app and some education of how to use it, and we'll see what the utilization of that app would be, as well as how many people end up on these drugs in the future, versus a control group who will not get this. They'll get this education, like lectures like this, but they won't get the actual detailed app. So I think that will be a huge step forwards for us, and then perhaps it could go to other clinics beyond that.
That's a great idea. Yeah, I know that when there's newer medications, we just reserve them to the specialist. But I think now, given that obviously the very high prevalence of CHF in patients with diabetes and waiting for appointments, really they're not being used at all. If you look at the actual use of these medications at the population level, there might be 7%, 10%. They're going up slowly. I don't know what happens. I guess it's a cost, obviously. It's a cost issue. With Medicaid, we cannot use GLP-1s. They're like really not approved in GLP-1 receptor analogs. But with Medicare, we get them covered. At Grady, we fortunately have everything. If the patient doesn't have insurance, we have canagliflozin. We have long-acting exenatide. So,
but I think the app even helps with that. You could work out which insurance is compatible with which drug.
Right. And I guess that the point of starting these medications in patients that are on diuretics, if they're on torsemide, for example, if the patient is euvolemic, many times we'll halve the dose of their diuretic when we add these medications and have a follow-up just to take a look at their volume status. Because the typical drop in volume happens in the first 2 weeks. There's studies with labeled albumin looking at volume, et cetera. But it seems like it's very early. It's a quite significant drop in volume. So that's one of the points. Maybe decrease the dose if the patient is euvolemic, decrease the dose of the diuretic, and add these medications if the patient has heart failure. GLP-1s are very well tolerated, so that's very easy to use in everybody. So there's not much of this discussion about volume, amputations, yeast infections, et cetera. GLP-1 is just prescribed to those, just need to teach them how to use it. That's, I guess, the challenge is how do we start this in any clinic if we don't know how to use this medication? So that's maybe having diabetes educator helps, or just learning. Sometimes when we don't have support, we always have support, but when I don't have time, I would just send them the link. I just email the patient the link, look it up, and then you can do it, and they can show it at the pharmacy too. So they will pick it up and they'll show them how to do it.
I think that's an interesting comment about decreasing diuretics. You could be talking about starting sacubitril valsartan as well. That's what we've learned, is that you need to decrease diuretics when you start that medication. So I think we need to pay attention to the clinical trials and the results, as we're seeing medicines that are now coming onto the market that have outcomes benefit. It's a little different from the 70s, when Dr. Logue used to say when a new drug would come out, he'd say, use the new drugs while they still work. That is, they came onto the market based upon their pathophysiology and other data, and then when the large clinical trials were done, they came off the market. But we're seeing a shift in that, and we certainly need to pay attention. So thank you very much.
Thanks.
The preceding program is copyrighted by Emory University.